Absolutely.
Yeah, that'd be great. Thank you. Good afternoon. We are going to start with a little experiential. So, everybody close your eyes. And I want you to imagine that you are in bed, and it is so warm and so comfy and cozy and peaceful, and you're in a deep, 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 deep sleep, sleeping so soundly. I'll just say, I'll give a little re-intro. We're doing a little experiential. Should I wait a minute, maybe, just in case? You think, yeah? Give everybody a couple more minutes. Okay. Well, for those of you who are in the room, imagine you're in bed. It's very warm. You're very cozy. It's dark. You're comfortable. And you're sleeping as soundly as possible. And dreaming. And while you're in your deepest sleep, dreaming in your warm, cozy bed, the covers get ripped off of you, the lights come on, it's cold, your alarm clock starts going off non-stop, but it's not time for you to get up yet. You feel perhaps your significant other is trying to rouse you awake, so they're poking, jabbing at you. The shades are up, it's bright, the lights are on, you're cold. Sort of the point of that was to help you imagine what it would be like to be a preterm infant who was born early. So they came from the most comfortable, warm, regulated, safe place into a place that's cold and bright and noisy. And then from that point, how music could provide comfort in that very scary situation. So I kept it brief. I probably should have brought you in and out of it a little more gradually, but I just wanted to give you a snapshot, I guess. This is the image that I have in working with these infants when I imagine what their world must be like and how it must feel to be out early and to be interrupted from such a deep, comfortable, warm place. And then what it would feel like then to be offered music and how that could comfort and bring them comfort. Does anybody have anything they want to share about the experience? I know it was really brief, but how it felt. I know it was kind of mean, too. I know, you imagine you're going to do an experiential and get all relaxed, and then it turned kind of mean. But, but I get that vision a lot, and that image a lot of sort of that must be what it feels like to be these infants. So I'm going to talk to you a little bit about, first I'll do an overview about how we work in the NICU, and then I'm going to get more specifically into how we work with pain and neonates, and then even more specific still about a case that I worked with for a long time. So, there has been a lot of research over the last few years. The research is just kind of coming out more and more and more in terms of how music therapy can benefit these infants. So, Mark Tremo presented, and he was fantastic, and if you haven't read his article about using music to alleviate stress during heel sticks, the outcome of that was there was a lowered, significantly lowered heart rate with music versus without music. And that's in our Music and Medicine, the journal that Joanne spoke about earlier this morning. And if anybody wants me to email them this presentation with all the research and all the references, no problem at the end. So don't feel like you have to write, you know, too much. Because I have several slides of research. This is a recap. If you were in Joanne's presentation yesterday, she spoke about the sedation effect. And so this is something, her specific study was with young children, I believe toddler age, but we apply this same principle to working with infants as well as working with other populations, but I use this a lot in working with infants. So this is another research study we applied to music therapy in the NICU. She spoke also briefly about our Heather on Earth study, and that research was to measure how live music affects preterm infants. So I was a part of that research, as were, we had 11 other, well actually there were more than 11 music therapists. There were 11 sites, but then at each site there were other music therapists and interns doing the work. And this study was pretty much the first of its kind, in that we're really examining how does live music, particularly womb sounds, benefit preterm infants. So that's in publication, and it will be being released very soon. But that research is the basis for how we practice here. So we are working in an evidence-based way. Another page of just valuable research that we've had in our field is as far as music therapy in NICU infants. Again, I'm happy to email this to anybody that would like it. So as far as how I work in the NICU, I work from the medical music psychotherapy model, also from a developmental perspective, because we know, again, that for preterm infants, and I should also mention that we don't only work with preterm infants in the NICU. There are, of course, full-term infants that are born with medical complications, and so they get admitted to the NICU. Regardless of age, we're always looking at these infants from a developmental perspective. So how can what we're doing benefit their development? How can we be looking at them through this developmental lens? And then also from the trauma-informed perspective, because as you can imagine, it's very traumatizing to them physiologically, it's traumatizing to them emotionally, it's traumatizing to their caregivers because they are so fragile. There is so much medical intervention and painful intervention that's needed in order to sustain them, and therefore they're in sort of a constant place of being traumatized. And it's such a difficult sort of dichotomy because, of course, all the medical interventions are so very necessary to sustain them, but at the same time, they are experiencing pain most of their early days. As far as why infants are referred for music therapy in our particular program, and it's different at every hospital, but just speaking from the way that we receive referrals, the medical staff, the social worker, sometimes the parent themselves, sometimes music therapists, we notice an infant that's in need, and so we'll make go to the team and say, this is a new admission, and can we start working with this infant? These are the areas that we work with and why the infants are referred for music therapy. So we're working complementary, of course, to all the other therapies as well as the medical staff. So one of our huge areas is sleep, sedation, and pain, which obviously is going to be the focus of this presentation, but these are the other areas that we can work. So infants that are referred for music therapy have to typically be over 32 weeks gestation. There are exceptions, so if the neonatologist feels that a 30-weeker is stable enough for us to begin music therapy, then with their permission we go ahead. But we always get the permission of the neonatologist and consult them prior to beginning music therapy. And that's just because there are often contact precautions, there are often airborne respiratory illnesses that we can contact. There are often on such a high vent setting that to introduce music in addition to the sounds that they're already hearing inside the isolate would actually be contraindicative, because the vent itself can already be above 55 decibels, which is the max level for them. So all those things we take into consideration. And we do get parental consent before we start with any infant. And again, we meet with the physician and the treatment team and get their clearance. Joanne touched upon these womb sounds yesterday, so I don't want to be too repetitive if you were in her presentation. However, the way we work in this NICU and the way our basis for treatment and the reason we did our research study was because we've heard so much about throughout these couple of days how the body is an instrument. And for these infants, all of their regulation is coming from hearing mom's heartbeat, hearing the whooshing of the fluids in the uterus, even the rhythm of her walking, right, and that rocking feeling, mother's voice, father's voice. So we, as music therapists, are taking these elements and we're recreating them to recreate that womb environment and offer the infant self-regulation, comfort, to feel like they can sort of return to that place in an auditory sense and hopefully then bring them comfort. This is a photo that we use a lot. Again, we would never offer all these interventions at one time, but it was just to demonstrate that here's the gato box, which we replicate the heartbeat on, the ocean disc, which represents the whooshing of the fluid sounds that they hear, and then we always use a lullaby or song of kin that the family member brings in. And again, I know Joanne went into that, so we just really, really feel that it's important to honor the culture of every family. So we get families who mom and dad's wedding song was Living on a Prayer by Bon Jovi. So we're going to turn that into a lullaby, because that is the song that's important to them, and that is the song that they identify with. It's really fun to build up our music folder and to take a look back at all of the music families have brought in and the ways that we've worked with them to turn that into a lullaby for their infant. So we can take any song, put it into that 3, 4, 6, 8 rocking meter, slow it down. Often we don't use all of the lyrics because that's a lot of language for an infant, so maybe we'll just take one key sort of phrase and repeat that and insert the infant's name, or sometimes parents want to rearrange the lyrics. So when we're assessing, the main elements that I'm assessing as a music therapist is how do they respond to the gato box, how do they respond to the ocean disc, and how do they respond to the song of kin or lullaby. If the parent is there, parent or caregiver is there, that's optimum. We would love to always have it be the parents that are singing versus our voices, because obviously the parents' voices are more important to the infant. And then beyond the assessment, we do work with other musical interventions with the infant, but these are our 3 main interventions when assessing. And I'll get a little more into more interventions as I go on. As I go on to the next slide, apparently. That was further in the presentation. I do go on even further in the presentation. But some of the interventions we do after we assess, depending on what the infant's needs are. So going back to that referral slide, whatever the infant's been referred for, we're going to use interventions to match the referral criteria. I won't get so into that right now because we're again focusing on pain, so I'm going to mainly explain to you how we work with infants in pain. But we do work with coordinating the suck response for infants that are having difficulty with feeding, and things like that. We work closely with the families, and as much as we can work with the families, the better, the more the better. The work that we do with the families is so precious. It's my absolute favorite work to do. And we can work with them at the bedside. Sometimes we meet with a mom or dad in another room, and we just offer them music-assisted relaxation because we see them at the bedside and they're just so anxious and so traumatized and having such a difficult time, and they just need a moment of respite. So we can offer that. And again, the idea is helping to calm and helping mom and dad achieve a place of relaxation, and their own physiologic stability is going to translate to their interactions with their infant. So we are benefiting the infant in that way. You see so many moms and dads, and it is so understandable, at the bedside, and they're pacing, or the first time they get to hold their infant, the infant is connected to so many different things, and they're so nervous, and they're so anxious, and you can see it. They're so tense. Well, the infant is feeling all of that because they are so physiologically disorganized, and they're really supposed to still be organizing off of mom. And so now they're out here trying to figure out how to organize, and they don't have anything to organize them. So again, we know music is incredibly organizing, so that's one of our huge philosophies for why we do what we do. But we can work with mom and dad in helping them organize, so that translates to the infant. So if mom is holding the baby and she's just done the first feeding, and now then she's got to burp the baby, and it's time to burp the baby, and we can sit with the gato box or the guitar, and we all know about entrainment, and so we can entrain mom subtly. Obviously, we're not going to state, you need to calm down, so here's what we're going to do. We can very subtly entrain mom to the music, which then gets translated to baby. And so now we can all get into this very organized place, which is ultimately going to benefit the infant. The more relaxed these infants are, and the more they sleep, the more calories they conserve, the more they grow, and the faster they get better and get to go home. So, Joanne was speaking about how important it is for us to be able to put people to sleep. It is so important to be able to put these infants to sleep. They're, conserving calories, resting, and growing is so important to them in order to get better. And that's regardless of if they're preterm or full term, because when they are admitted to the NICU, even if they are full term and they were perhaps at a healthy weight, again, due to the nature of the environment and the trauma and the medical procedures, they're already in a state of anxiety. Chances are they're losing weight. They may have surgery whereby they can't begin feeding. They're getting a feeding tube, all of these things. So one of our huge goals is how can we help them to rest and to conserve calories? And we all know that music can help us to rest. Another huge part of working with the parents is just teaching them from a developmental perspective. So as these infants are getting older, if an infant is going home, that is going to go home with home care, or they're going to have some sort of weekly or daily procedure, or they're going to need to get continuous doctor visits. We can give mom and dad the tools to use music for all of those different appointments and interventions, medical interventions, so we can teach them from a developmental perspective how to work with the infant, how to give them transitional songs. So we have a song for when it's time to go see the doctor, and we have a song for when you got your shot and you did such a great job, and now we're going to have a song to go home and to celebrate that. And so we use all those things, but also for We do get infants who stay in the NICU for a very, very long time. Just last year we had 2 infants who were there from their very, very premature birth of 23 and 24 weeks all the way through 8 months. And so you have a baby who's growing and developing in a NICU. And a NICU is not designed to encourage an infant's development in the cell, which I should make a disclaimer. Of course, the staff is so concerned with development. I mean more of normal infant developmental milestones, tummy time, or reaching and grasping, or tracking. You know, these are all non-medical issues that the medical team doesn't necessarily have time to work on with the infant. As music therapists, that's something that we can do. So whether it's taking instruments and helping them track and learning songs about body parts and colors, those are all things we can do with mom and dad to normalize the environment and the experience, as well as work on infant development. So that's a big goal for us as well. So when we are working with infants in pain, there are a number of pain scales out there. There are 2 pain scales that we use because of our site. So it's not because we, the music therapists, necessarily chose them. However, I'm a big fan of both of the scales we use, but it's because those are the pain scales that the medical staff is using. So I'm here at Beth Israel in this NICU, as well as at St. Luke's Roosevelt. There are 2 different pain scales that each hospital uses, but they're both excellent. There's the ATIA pain scale, which focuses strictly on the behavioral responses of the infant in relation to the pain that they're feeling. And then there's the premature infant pain profile, which is looking at the physiology as well as the behavior. So for us as music therapists, we carry copies of the pain scales. The nurses do chart their pain every few hours, and then particularly when there's a procedure, so we can refer to that pain scale. I've had a lot of nurses who want to take a pain rating pre and post music therapy intervention, which is really, really helpful. So I'll explain those a little bit more. The premature infant pain profile is, again, it's physiologic and behavioral responses of the infant, as well as age, because we know age is a huge factor. When we have an infant who's in 28 weeks or less, just touch is pain to them, because their skin isn't fully developed yet. So you can imagine that they're in a fairly constant state of pain. So we're looking at their age, their behavioral state, their heart rate, their oxygen saturation, and now we get into the more behavioral aspects of how they're reacting to pain. The brow bulge, the eye squeeze, and the isolabial furrow. So basically, their facial expression, the grimacing, how much pain are they in. And we're looking at all of these, and then it gets scored as followed. You add up those scores. I should go back for a second, I'm sorry. So at the top you see 0, 1, 2, and 3. So you take the infant's age, and then you take, you know, if you had a 31-weeker, but their heart rate was over in the 0 category, so you're still at a 1, but then their oxygen saturation was at the 2 category, so now you're at a 3. I don't know if this is making sense, but you're just adding up the scores from the different categories. So 6 or less, they actually score as minimal to no pain for that infant. 7 to 12 is mild to moderate pain, and more than 12 is moderate to severe pain. So this is something that we're always looking at as music therapists working with these infants, because it changes constantly. It's constantly changing how much pain they're in. And of course, depending on intervention, depending on if they've begun feeding and they're having issues with feeding and they're having gas. I mean, gas alone is enough to really cause a lot of pain for these infants. And then it's taken every 12 hours initially. However, of course, if there's a procedure, it's taken pre and post. And like I said, I have had a lot of nurses who like to take it pre and post music therapy intervention so that we can compare. And that scale is the one we use at St. Luke's Roosevelt, and then the ATIA behavioral pain scale is the one that's used here at Beth Israel. Excuse me, this one is based primarily around the behavioral responses of the infant. Again, it's scored similarly, and we're looking at cry, facial expression, sleep, because of course how quickly they can sort of recover and fall asleep is huge. Their motor movements, sucking, as we know, for infants, there's so much in the nursing literature about sucking, non-nutritive sucking for pain. It's encouraged, so a lot of times we'll give them a pacifier, or mom or dad will hold them during a painful intervention and they'll suck on their finger, because sucking really can distract from pain. We look at tone, consolability, and sociability. So did that pain just cause them to completely turn inward? And if so, we're gonna score them pretty high. So for this one, oh, forgive me, it's the flip as far as the score goes. So for the other one, it was greater than 12, they're in the most pain. For this, it's 0, they're in the most pain. So every pain scale is different. If you're someone who's working in a NICU or working with infants, there are a ton of pain scales out there, and you can see whatever is the best fit for you, what is the most realistic. If you don't have the ability to look at the physiologic measures like heart rate and such, then this is probably a great pain scale to use. So I just wanted to take like a little glimpse at how pain is, I'm sorry.
Expressed.
Thank you. I'm like, there's a word on the tip of my tongue. How pain is expressed for infants. And then what music does on the flip side of that. So most often we're looking, this is just physiologic measures. It elevates infants' heart rates, it elevates the blood pressure, it elevates the respiratory rate, and then there can be a decrease in oxygen saturation. Now, not each of these things happens to every infant every time they're in pain, but these are the physiologic things that we're looking at to discern how much pain they're in. And then, as we know, on the flip side, what music can do. It can lower the heart rate, lower the blood pressure, lower the respiratory rate, increase oxygen saturation, and decrease the pain response. So this is a nice little overview for why music can help with the pain reaction of neonates and stress. I use pain and stress sort of interchangeably for them because their systems, again, are so dysregulated that stress is pain and pain is stress. So it's fairly interchangeable for them. When we are looking at who is referred and why they're referred, when we're giving our sheet of possible referrals to the medical staff to explain why an infant would be referred, this is our explanation for how music therapy addresses sedation, sleep, and pain. So to provide an environment of safety during painful procedures. So we can be there, as I kind of tried to give you in that experiential, that music was a little glimmer of hopefully comfort or safety in what felt like a very unsafe place. So oftentimes we're there during procedures and we're there to offer this environment of safety to the infant. The way we do that is we match the pitch of the infant's cry, and then we can sort of bring it down and use that principle of entrainment. If you were in Yoka Brat's presentation yesterday and she was talking about the headaches, and she was demonstrating going way up into the head and coming down to the core, it's sort of the same philosophy. When an infant is crying, we're mirroring that cry in a sense. We're matching that pitch and we're bringing it down. And we're matching that pitch and we're bringing it down to a place where we're saying, we hear you, but let us help you calm. We hear you, but let us help you calm. And we're using the principle of entrainment that way. Obviously, music can help with the reconstitution after the procedure. And then we can use it in conjunction with pharmacological treatment, but we don't always. It all depends upon the MD. We use lullaby and, again, the womb sounds. So these are the ways that we use music to specifically address pain. this is just stating again the different things we use. Tonal vocal holding is the idea of toning for regions of the body, which we've heard in a couple of presentations, based sort of on the chakras. And so if an infant is having gas, we're going to tone on the O vowel down in the stomach. If there's a chest pain, and I have a fun little diagram, chest is going to be more of the A across the chest. The head is the E, I, E. So it's a little bit different than just where the tones lie in the body, because it's based more on the chakras. Oops. There we go. And then rhythmic entrainment of non-nutritive sucking is another thing that we can do with infants who are experiencing pain, as I've already mentioned. And I have a video clip to show you. In this video, I'm not working with an infant in pain. I'm working with an infant who is learning to entrain their suck so that they can eat. However, you'll see how we use the gato box and the principle of rhythm and modeling the suck response for entrainment to encourage the infant to suck. So this is from our website, our NICU website. Down near the speaker. So for that infant, she wasn't in pain, obviously, at that time. However, her suck was very undeveloped, and she was having difficulty bottle feeding. And so for her, giving her a pacifier to coordinate suck to alleviate pain during a procedure is not going to necessarily be beneficial because that suck is so weak. So as we work on developing the suck, that also can translate into helping to ease her during a painful procedure. So, and we do often offer the pacifier and use that principle of entrainment so the infant can focus on the rhythm of our sucking, as well as, I'm sure you noticed at the beginning, I'm doing some breathing with her as well. So we can help them to entrain to the breathing and the non-nutritive suck during a painful procedure and sort of integrate all of those things. We can hopefully lessen their pain experience. Oops. Does anybody have any questions so far? I don't want to be moving too quickly. Or yeah.
Do you work with an OT or a speech therapist when you're doing any of the developmental or the sucking and swallowing?
We, unfortunately, in our NICU, there is not an OT or a PT or a speech therapist NICU specific. There are those modalities in the hospital, and what they'll often do is in the event of like an infant with a genetic disorder, perhaps, who has, extremely low tone, or who's got some sort of even malformation of the mouth or face, they will then bring in a consult for speech or OT, and in that instance, yes, I love working with them. Whenever we can work together, it's wonderful. We did have 2 little boys, the ones I mentioned before, who were in the NICU for such a very long time. At that point, they were there for so long, they were bringing in the child life specialist, OT, PT to work with them. But our normal population of preterm infants don't get speech therapy to help coordinate their suck. It would be wonderful. The nurses are amazing at helping them really coordinate the suck, and we've been timing it out. Our nurse manager is very supportive of music therapy, and so she wants now for us to time it out where we can sit with caretaker nurse music therapist, and I'll be working on, entraining that suck, swallow, breathe response.
So I just want to make sure I'm understanding that, because I haven't worked with preemies before. So the auditory cue of the suck stimulates them to have a stronger muscle response, sort of like gait training, kind of
exactly.
in the same way?
That's what we're hoping for, exactly. And it takes a long time sometimes.
I just wanted to ask
yes,
you about
yes. As you saw with that little one, it was after a while. Then you kind of saw her chin get into it, and she's kind of starting to do it. It can take a very long time, and it can be over the course of several sessions, and then other times it happens instantly. So it kind of just depends. It's just them trying to get organized, and us trying to assist in that organization by giving them something to entrain to.
But the principle is very similar to
yes.
gait training.
Yeah,
that's what I was
is.
wondering, because I was talking to a neonatologist, just happened to be over Christmas, and they don't have music therapy in their NICU up in Trenton. And so I was, as somebody who works in end of life, but works with peds and works with frail people, a lot of these are applicable interventions.
Yeah,
but I never
absolutely.
thought of it in terms of inducing, that suck response that may or may not be neurologically even well formed when
right.
somebody is that premature.
Right.
And what did they do before music therapy? How would they?
Yeah.
Other than the pacifiers, which I heard.
Yeah, and the nurses, they do try to work with them with the pacifier as much as they can, but we have a very busy NICU, and I mean, we have some very, very severely sick infants, and so you could see where what they're really hoping to do is get the caretakers and the parents involved in that, in stimulating that suck response and working with the pacifier, and so when there's not time, it's there's not time for them necessarily to visit every bedside and try to work with and training the suck of every infant. So it's wonderful when we get to be a part of that, because they're spread very thin. Those nurses, they do the best they can, but.
And have they shown that have you studied this? Have they actually shown the efficacy of this?
Well, part of our womb sounds, our research with our womb sounds was using the heartbeat pattern on the Gato box. It wasn't always for suck, but we did use it for suck at times. And we did look at, over the course of the treatment, if the infants were eating more post-music therapy. So I think it would be fascinating to take that, whittle it down from, all of the interventions, and do just a study on that. I think that's a great idea. Definitely. Thank you. Okay. So here again is the tonal vocal holding for the bodily regions that we use. Okay. So just to kind of revisit what I was speaking about prior to this about the families and helping to sort of get them organized when they go to interact with their infant. This is the theory behind why we're doing that. And I think, again, I think Joanne spoke a little bit about this yesterday. And then, of course, Dory spoke about the fight or flight mode and wiring in that mode. For these infants, their brains are still wiring when they come out prematurely. And so they are really wiring in that fight or flight mode as just a survival mechanism. So how music therapy can work with them, but in the bigger picture, how we can work with the families, again, for that organization piece and to help with self-regulating moms and dads, to then help with self-regulating with the infant. So here's just some of the research behind that and some of the ideas that we use and principles we use in working with them. So an important role for music therapy is to assist the parents in becoming grounded. And again, this will ultimately impact the infant's ability to self-regulate. And when Kristen Stewart wrote about patent patterns about assessing trauma all around, from the caretakers to the infants to even the medical staff who are sometimes traumatized by these very complicated cases, it's important to assess where everyone is at before we can really work on grounding them with music therapy. Parent-infant interactions which are loving, grounded, and stable can prevent the infant from wiring under a constant state of trauma. And music therapy can foster this relationship, lessening the impact of pain and stress on both the baby and family. So I have a beautiful example of this where John and Bernardo and Andrew all worked with a first-time father of twins, 32-week premature twins, and naturally the parents were having a difficult time with the baby's premature birth and subsequent admission to the NICU, and the father was a singer. And this is one of the instances where John and Bernardo and Andrew worked with him outside of the NICU environment, and they worked with him to work with him on his music, what his music was, and to validate him in his music. So he then brought that back to his wife and the infants. And so it was sort of a full circle of grounding and stability and sort of lessening the traumatic experience of being in the NICU. So, just pull that up. It's a really very beautiful video, and working with fathers is becoming, you know, we're trying to focus on that more and more and more, because they are such a sort of underwritten about in the literature. Everything is about mothers, but fathers are there. Brian's nodding. It's true, fathers are there. And Brian and I spent some time with a father, didn't we, when you were here in the fall? And it meant so much to him. You know, they're just as important to the infant's development. So I think this is a beautiful video to illustrate that. Mom did not fancy herself a singer, so she was pretty self-conscious about singing, but it was so beautiful that they were able to work the Song of Kin, the music that was important to the father, and you know, he was really able to get into music therapy and to use music therapy as a tool for coping with his infant's hospitalization, and bringing his wife into that and bringing their infants into that. So they did beautiful work with that family. And that's just a way that music was really used to help ground the whole family throughout their experience. And this is just a little bit more, again, about wiring under pain and fear and the stress response and how that affects the infants. Porges has written so much about this in the literature. And what I love that he says is that safety trumps fear. I love that. Because if we can, as music therapists, assist the families and the infants in feeling safe, that can ultimately trump the fear that they're feeling. Even the inherent fear that they're having to a painful procedure, and even the trauma that they're experiencing, we know music therapy is powerful enough to trump that, and I love that quote. And so just to sort of wrap up that concept, providing an atmosphere of safety despite the painful procedures that they're going through, and often several a day, via musical and a non-musical relationship can provide corrective experiences and then ultimately impact the infant's development. So I'm going to kind of wrap that up with telling you a little bit about a case, an infant that I worked with last year. He was born with Zellweger syndrome. It's an extremely rare genetic disorder. And the parents had no knowledge prior to his birth that there was anything wrong with him. He was born floppy with a few abnormal features, and one of the biggest things is there is really no ability to suck. There's no suck response. And then it affects how the body metabolizes substances, and so because of that, they often get a stomach tube and often a trach, and life expectancy is typically around 6 months. Oh. So there's not a good outcome for these infants. He specifically was referred to music therapy to support that suck, swallow, breathe pattern because there was the hope that perhaps he could do a little bit of feeding by mouth and coordinate that a little bit, as well as, again, just to be able to self-soothe with a pacifier if possible. He was also referred, the family was referred to promote bonding for them and to provide support during such a difficult time. Music therapy was referred to calm and soothe him because he had a lot of procedures he needed done. And initially, when he was born, you know, they don't have these diagnoses right away, so it involves a lot of blood draws, a lot of screenings before they find out what the official diagnosis is. So right off the bat, we were called in to help with all of those procedures, and then also to provide stimulation because he was a pretty non-responsive infant. You could tell when he was in pain, and aside from that, there really was no responses. He did, in addition to Zellweger, it is accompanied by often very low cognitive function ability and mental retardation. So what he was able to take in was pretty unclear for a while. The first session I had with him was actually when his dad was there at the bedside with a pacifier and pretty frantically trying to get him to suck. This was prior to knowing what the diagnosis was, and so you imagine as parents, and I should have mentioned, he was actually a full-term infant. So for a full-term infant to come out of the womb with no interest or ability to eat is very scary for a parent. So the hope was maybe we can coordinate his suck response on the pacifier. And so as the music therapist, there's a lot going on for this family. I can recognize right off the bat how much trauma they're experiencing. And Dad was a very sort of jovial man and trying to keep spirits up for himself and his wife. And so for that first session, we just did very grounding rhythm and modeling of the suck response. Something very tangible. We didn't get into Song of Kin yet. We didn't get into songwriting because my sense was that just below that jovial surface, things were very fragile. And so to do something very tangible and very hands-on, so I worked with the gato box and I showed Dad how we can model rhythm and suck response and entrainment. And it was something that he took those tools, and every time he was there, he was modeling that suck and modeling that breathing and working with his infant. The next session I had with him was the assessment, and then the following session was working with Mom. And she was very open, and she was extremely enthusiastic about him receiving music therapy, any type of stimulation or complementary therapy to perhaps spur on some reaction or some development was ideal for her. She was really excited about it. She was really open with me from the start about how she was feeling, how she was taking this all in, and she already was one of those people who really used music in her life, so it was an easy relationship to form as far as how we could, use music therapy for her. So I thought it was interesting because you know how as music therapists you have those sessions sometimes and somebody brings in a song and you're like, okay. And then it's not till later you're really looking at the song and you're like, oh, okay, now I get it. Now I get why they brought that song in or what that meant. It was actually in supervision with Joanne where it occurred to me and her as we were discussing it. Her first Song of Kin was Our House. And Joanne said, wow, she's really searching for normalcy amongst all of this, isn't she? And I was like, oh, it's a song just about a normal house, fire in the fireplace, dogs in the yard, playing, just normal everyday life things that these parents had anticipated having up until the moment of this child's birth. They had his nursery ready, they had a name picked out, they had clothes for him, they had the car seat, they were ready to give birth and come home. And now he's in the hospital with an unknown diagnosis with very severe medical complications as a result. And they're spending all of their days in the hospital. And so I thought that was really interesting that that was her first song that she brought in. And that was the song that she sang to him every day. So we had this sort of routine we started to do with him. We had songs for certain things throughout his day there, and he was there for several months. And as his care became more complex, as he got a feeding tube and a trach, she began to have songs for each of those. Now it's time to, hook up his feeding tube, or now it's time to suction the trach. And so she was someone who just really used music for each transition. And she had this other beautiful song, My Own Little Corner of the World, by a group called Yo La Tango. And it was sort of, that song is sort of more about feeling isolated and feeling alone and feeling like you just need to have your own little space to sort of process everything. And then Rainbow Connection, I don't want to assume too much. That song actually came later, and I feel like that song is sort of, we might be thinking about things beyond this life and beyond Earth, and so maybe as she was grasping his diagnosis and his actual life expectancy, that's where she started to go with her song choices. But she was diligent. I mean, we had sessions at the bedside every single day. And again, we had sessions sort of structured around what he was going through as far as his pain. So suctioning was a very uncomfortable thing for him. And I would be there with my guitar, and Mom had a song that she would sing every time he was getting suctioned. And we would work on entrainment, and then we would work on, the sort of reconstitution piece and the breathing after, not just for him, but for Mom as well, because it was so difficult for her to have to sit there and watch her infant get these painful procedures done. Just going to check the time. Okay. For him, his outcome medically looked fairly hopeless. And as he became more and more involved, it was clear that, he couldn't breathe on his own. He couldn't eat on his own. Again, his reactions were pretty limited to any type of stimulation. However, for not just the family, but for the medical staff, music became his identity. So his mom made this sign that hung above his bedside, and it said, "Hi, my name is Liam. My birthday is, my favorite thing is music. I love when the music therapist and Mommy have my music time together." And then she had a list for the nurses for when she wasn't there of music she wanted played during certain procedures, or we would time it so that I would be there and I would reassure her, we'll do this song, we'll do this breathing with him during this test. He also had a clubbed foot and had casts, and so they were always sort of working on realigning the foot and the legs, so that was painful for him, so we had music for that. And it sort of became his identity. So instead of being the sick baby with Zellweger syndrome, he was the baby who loved music, who got music therapy, and whose mommy loved music, and whose mom sang to him every day all the time. And he was there for several months, and she brought a lot of musical toys in and musical things. And so it was really important and pretty amazing to see how she used music. And as I said, not just she, but the staff used music to form his identity. So he wasn't just this sick baby. So that was a beautiful thing. And then for the family, to be able to validate them and to empower them. I mean, we did write some songs together to help with stress reduction. It was easy to see that if there was a day the parents couldn't be there and they knew he was having some sort of procedure, to be able to tell them, myself or the intern will be there at his bedside offering musical intervention, obviously is going to bring so much comfort and stress reduction to the family. It also really, really facilitated their bonding, I believe, and then offered the parents some respite. So it was a very important part of their hospital journey. The extremely positive outcome of this situation is that this was a year and a half ago, and he was discharged from the hospital, and then he sort of was readmitted to the PICU several times, and each time I would go and see them, and we would do music, and just probably 3 or 4 months ago, Mom brought him to the unit to visit the staff, and she was pregnant with her second child, and he's still alive, so he's past his life expectancy, which is pretty amazing. And they're hopeful, however, they're also realistic. But he was sent home with like a palliative care nurse, I guess, an infant palliative care nurse, or hospice nurse, to receive home care because they were very much set up for what the expectancy was going to be for him. And I think it's pretty miraculous that he's outlived that expectancy. He has a lot of complications, but the medical staff did say that they felt that even his awareness had increased. So I'm happy to not have to end the case by telling you that, you know, what the future will bring, we're not sure. But we know that music played a huge role in alleviating his pain in the hospital, and that Mom and Dad took all of that home and continued to use that at home throughout all the treatments that he receives. So I have several pages of references that you don't have to write down or anything, obviously, but again, I'm happy to send you. But does anybody have any questions or comments?
It's beautiful, the work that you're doing. My question is, when you train the father with the help, did he actually use the gato box? Was he touching the child? How did he do the rhythm?
Oh, sure. He was holding the baby, and he had the pacifier, and was holding the pacifier in the baby's mouth, and I had the gato box, and so I gave him a rhythm, and so I didn't give a lot of verbal instruction, because again, working with parents that are in a traumatized situation, you know, we don't want to like, now we're going to do rhythmic and training for non-nutritive sucking, you know? So it was like, let's see if a rhythm will help him suck. Sometimes that helps babies suck. So I just demonstrated the rhythm, and then I said, and we can model the sucking. So then I started doing the So then Dad started pulling and pushing the pacifier in to the rhythm of the gato as well as to my suck, and then Dad started modeling the suck noise as well. So just trying to help him and train to that rhythm. Yeah.
How do you discover what that rhythm is for that child? What is your method of knowing exactly?
When we're working on actually feeding them, it's whatever sort of initial suck they're giving me on the bottle. For this, and you know, and so I sort of try to lock into whatever the initial suck, because often they have a suck response, it's just very weak, and they get very tired because it's not developed fully yet. So we're sort of trying to give them rhythmic stamina to keep going with that pattern they're in. For this particular infant, there was no suck response whatsoever, and that's part of his diagnosis. So that was just established by picking a rhythm, and
had the experience to kind of know in general what would be good.
I mean, I knew it was going to be very difficult for him, so I know he's not going to be able to give me a strong, vigorous suck, so we just started nice and slow and went from there. Yeah.
And the NICUs that you're in, do the infants have their own rooms, or is it one general room?
No, they are, at Beth Israel, we have 3 rooms, and then there's an isolation room. And I should mention, I'm sorry, that my colleague Melanie works in the NICU as well here at Beth Israel, and that Brian Schreck is part of our Rhythm Breath Lullaby International NICU Music Therapy Training Program. So and then Dr. Telsey, one of our neonatologists, is in the back there. So I just want to acknowledge them, because, what's that? Oh, and Maya. Oh, I'm so sorry. Yeah, I'm so sorry. And Maya is also doing the work in California. Sorry. And is our Rhythm Breath Lullaby trainer out there. You look different with your hair up, so forgive me. So what were we saying? We were saying...
One room.
Yeah, I'm sorry. Yes, I'm like, I got way off track. Okay. So here at Beth Israel, there's 3 rooms. So it sort of varies by the severity of the infant. So the first room is the infants that are most severe as far as their diagnosis and illness. And then the second room is slightly less severe. The third room is considered step down. So those are the infants that are waiting to go home and they're about to be discharged. It's the same setup at St. Luke's Roosevelt. We do have an additional unit we open up as the step down because it does get overflowed quite a bit. And each unit also has an isolation room if the infant does need to be in isolation.
So you'll work with one of the infants with the other infants in the room?
Yeah, because we're at the bedside and everything we do is individualized for that one infant, although we do offer environmental music at times in the rooms or on the unit. But when I'm working just with an infant, I'm opening their isolate doors and I'm working just with them and I'm entraining off of just their vitals. And the music we offer is so quiet at the bedside, it's just that infant hearing it. Yes?
I was called by a panicking mom in the Bronx and asked if I could do some work with a little baby, very premature baby, and she was a doctor there at the hospital, but they didn't have a protocol for giving music therapy for neonatal babies. So I'm wondering if you have a certain protocol that you have written up that gives the hospital permission to give the babies music therapy.
We do, in the sense that everything we've done is because this program's been established for many years and has been in consult with Dr. Telsey and Dr. Sharvar, who oversees the NICUs, so they're aware of how we get referrals, what age we're referred. All of our documents have been approved by them as far as the assessment, referral criteria, and follow-up sessions. And then we always get the neonatologist's permission prior to beginning with a child. Then we do have policies for touching and holding.
Yeah.
So it's not, we don't touch and hold every infant, and it's certainly not a necessary part of our music therapy as far as we don't have to hold every infant that we work with, but we do hold them when we feel it's needed. And using that clinical intuition, you know, a lot of these infants are on caffeine, and so they might be having a really difficult time regulating, so we might place a hand on the feet and a hand on the head inside the isolate to offer them some regulation. We can take them out and hold them, but we have a holding policy that's been passed through the head of our NICUs, Dr. Sharvar, and then our neonatologist and Joanne, so everyone signed that. And
is that published so that other hospitals can
I know, because I
get
think
one, or what?
I mean, we have a copy of it, but it's just like it's just a policy stating that we have permission to hold the infants when necessary as part of our treatment.
Okay.
And our Dr. Telsey, is there anything you want to add to that? No? Okay. I thought maybe your hand was going on. But Joanne would be great to speak to about that. Yeah. Yeah, she would be able to tell you how to maybe formalize more of those things. Anybody else?
I think we're over time, but I just wanted to ask you how you use music in addressing loss in the NICU, because there certainly is loss.
Oh, yes.
I'm sure you address that in being,
yes.
I work in pediatric hospice, so I'm just kind of aware of the other end and outcomes.
Yeah, absolutely. Most of the time when there is loss, we will have some type of memorial service with the family, and music therapy is a part of planning and executing that, and offering music that's significant to the families. Then we also have a bereavement service every year in the fall here at Beth Israel, and in the spring over at St. Luke's Roosevelt, where the whole service is for anyone that's experienced the loss of a pregnancy or child. And so the families come, and there's an open forum for them to share their stories, and we offer music throughout, and we do typically like a group song at the end. So yeah, we're a part of planning all those memorial services, and we're there at the bedside if they would like us to be. Yeah. Thank you. I'm so sorry that was. Thank you so much.